is an exciting topic for me. If your life is anything like mine right now, the pandemic has affected everything. You're still doing some of the same things, but it's a little different, a little more intense. The volumes are a little higher. So this session is really aimed at stepping back a little bit and figuring out how many of these changes are permanent. How has the pandemic really affected how we're going to do business going forward in the healthcare community? So our official title, Pandemic 360, How Clinicians, Health Leaders, and Consumer Behavior Has Changed During the Pandemic. We are going to talk about consumers, payers, the way that we're delivering care, how we're staffing care. And we have two great individuals to talk about that, Ben Isker and Travis Singleton. Ben leads PwC's Health Research Institute. HRI is a dedicated research group that provides new intelligence, perspective, and analysis on major health-related business issues. In his role, he oversees thought leadership and research initiatives. Prior to joining PwC, Ben developed health policy as a legislative director in the Texas House of Representatives and as a government relations officer for the city of Austin. Travis is with AMN. He serves as the Executive Vice President for AMN Healthcare's Leadership Solutions Division. This division of the nation's largest healthcare staffing organization includes Merritt Hawkins, B.E. Smith, and StaffCare. This firm provides search solutions for permanent and temporary physician and advanced practitioner staffing, interim healthcare management, and executive leadership roles. My sister works there as well, and I know that they have been doing so much work across the nation during the pandemic between setting up temporary spaces, providing staffing for any number of hospitals from coast to coast. So they have amazing insight and will share with us what they've learned during this time. Ben?
All right. Well, thank you, Kenya. And I'm going to go ahead and share screen here so we can see a few visuals that Travis and I have as we walk through. So let me give me just 1 second as that gets going here. Okay. All right. Well, let's just jump right into it, because actually the way we have it set up is I'm actually going to give just a few minutes of framing comments, and Travis as well, and then we'll go back into kind of interaction and questions. And my job right now is to kind of take us through what are consumers thinking. And the reason we know what consumers are thinking vis-a-vis the pandemic is that we have surveyed consumers 3 times over the course of the pandemic so far, with some of those questions being things that we actually asked prior to the pandemic. So we have some time series and we can see some of those changes. One of our survey sample was actually a 10,000 person survey across the United States, which is extremely large. Most consumer surveys you see are going to be about 1,000. The reason we dug so deeply, so we could show you like what we have on the screen now, we can really dig into some of this data. What is it that consumers are experiencing? So here we're looking at consumers with employer-sponsored insurance. So no Medicaid or Medicare, this is just employer-sponsored insurance for this cut. And you can see really almost a quarter of consumers have delayed care during the pandemic. And I think that's probably not a big surprise to most people on this call, but the average amount of care they're delaying. So we asked them, if you think about all of your visits and procedures and all those interactions, how much of it have you put off? Overall, about 70% of care has been put off during this time. But what's a little bit challenging is when we look at who's putting off that care. And so we look at 32% of those with complex chronic conditions. That's the exact opposite of what we want. Those are the people that can least afford to put off care. And that's even really a delay, not to mention, not seeing the doctor at all, but even just delaying can be a big problem when you're trying to manage a complex chronic condition or a mental health condition. The good news is a lot of consumers are saying they are rescheduling or they're planning to reschedule. Some of that is having to do with access in different hotspots around the US, which can provide some challenges to that. Whoa, we skipped a lot of slides there. Hold on a minute. Excuse me, folks. A couple of other just things I want to mention as we get into this. What is it that we're feeling because of the economic issue? And so we looked back at what happened in 2008 during the Great Recession. And as the unemployment spiked in 2008, the natural, the natural feedback from that was that we saw this huge dip in employer-sponsored insurance. And so I think we can expect that. Already we've seen some numbers, about 5 million people have lost their employer-sponsored insurance. This puts a lot of stress on individuals. What is that stress leading to? Well, here we can see some analysis from our social determinants of health surveys. So this is where we're looking at not just kind of what's happening in the health system, but what's happening in people's communities. So what are people experiencing with isolation, mental health concerns, challenges around food and exercise. The red bars are prior to the pandemic, so about between 5 and 10% of consumers were saying these are issues for me. You can really see how many of these have popped up, in some cases doubling some of these challenges. And why is this important? Because actually these social determinants have an incredible effect on our health. We like to think that the health system takes care of people. In reality, the health system is only influencing about 20% of our health. The rest are things like genetics, our own behaviors, and really the environment around us, our communities. We can especially see how acute that is during COVID, where we've seen underserved communities of color being especially hard hit with COVID. Many people are their essential workers are having to be out there. Maybe they live in smaller homes. It's harder to socially distance. So a lot of these issues that are these kind of underlying societal issues quickly become a healthcare issue during a pandemic. One of the outcomes we see of that, of course, is consumers are using more mental health services, so much more utilization there. About 12% of consumers with employer-based insurance said they sought help for their mental health conditions as a result of the pandemic. Another 18% say that they're going to do that. The challenge right now is that it's very tough to access mental health professionals. For those of you that run businesses and provide health insurance, you know that many mental health providers are not in network, and it makes it very difficult for our employees to access these services in the times they need them most. That's a huge issue for employers because those with mental health issues and complex chronic diseases cost employers about 12 times more than a healthy individual. So it's kind of the multiplier effect as you move up the stair step in terms of cost. And so if you can help people manage mental health conditions, what that often does is help them manage a lot of different conditions. So a mental health condition tied to with diabetes is going to be worse typically than just diabetes alone or just mental health condition alone. So it's one of the reasons why we see so much investment and so much focus on mental health during the pandemic. What are some of the other changes we've seen in terms of delivery? Not a surprise to anyone here that we've heard about the telehealth explosion. Here's just a few numbers around that. I mean, our calculations are that about 16 million Americans use telehealth for the very first time during the pandemic. We think that's a very important number. It's a little bit different than maybe some of the numbers you've seen just in terms of general telehealth usage. We want to know, but are really new people getting into the system? And also, what kind of insurance do those new people have? One of the surprises was, look at that Medicare number. Almost 20% of new telehealth users have Medicare insurance. And that is, very different than what we've seen in the past when Medicare use of telehealth has been down in typically about the 1% range. So an incredible change there in terms of the opportunities and the delivery of care. And I think Travis knows better than most, like, what does that mean for clinicians, and how's the health system responding to that? Certainly from an employer perspective, we see almost all major employers now offer a telehealth option. You can see from our employer survey, and look at that number, it's almost doubled since 2016. So again, the consumers want it, COVID has kind of forced it, and employers are right there saying we need to make sure we have this benefit for our employees. Last thing I want to mention before turning it over to Travis is just, where are people getting information during the pandemic? And this is really important because there's a lot of misinformation out there, right? Or confusing information. And the number one, I think the number one place in terms of being a trusted source, of course, is still, the doctor. And that's always going to be an important connection. We see some of the other, government and other entities a little bit farther down. What I'm not showing here is kind of where people get their primary information from. Not to scare anyone, but a lot of that is from, social media, obviously some friends and family, and kind of mainstream popular media as well. The challenge with that is, are those sources able to really get into the depth that people need to make good decisions? So with that thought, I'm going to end it there, and I will hand it over to Travis. And Travis, I'll move your slides along as you give me a cue.
Thanks, Ben. I know you didn't want to scare us, but that's terrifying. To learn that's how we're getting our health information. So I'm going to, in the thought of this 360 view, I'm going to touch a bit on non-healthcare companies and what they're doing, responding to return to work solutions, some other things, and how that intertwines with healthcare delivery systems of all different types specifically. But, most groups out there now have talked to hundreds of all different types. And I cannot stress this enough. Regardless of the company, the industry, the structure, the fragmented nature, maybe you have independent contractors, maybe you have full-time employees, maybe you're part-time remote or construction sites, or there's any variation thereof. Everybody needs to have a return to work solution or plan. And this is of course enhanced by those groups that are highly regulated, essential, highly visible. Think airlines, think food processing, think education, government. There's some others, right? So, not to peek behind the curtain too much, I'll tell you that any plan's better than no plan. That's something, right? But to say they're all created equal is a big stretch. The favorite philosopher quote that I ever look at is, everyone has a plan, right, until the first punch. Mike Tyson, great guy. So he had it right on this one, right? And this is, and Ben, if you put the next slide up, this is as much working in an outbreak type setting or mitigating risk should you have an outbreak, as it is the solution for a safe and healthy work environment, giving comfort in an environment where folks want to come back in, they're productive when they come back in, all these types of things being considered. But it's a lot, right? And I stress a return to work plan is not a form that you fill out at the front desk and giving the front desk person maybe a thermometer gun, right? That's not a plan. One of my favorite things to do now is you go into any business and you all have to fill out those little forms. I always ask, so who reads these forms? I don't know. Well, what happens if I check this box or don't check that box? Or are you going to call me back and let me in? And they constantly look at you like, I don't know. I've even asked them, so what temperature is acceptable and what's not? And half of them say, I don't know, right? It kind of shows you that it's a thin veil, right? So we need to look at a more modular approach, certainly as no company of any type has planned for this investment. And not everyone's going to need everything, right? So we want to look at a modular approach that uses technology to their benefit, that hopefully gets it as far up front as remote patient monitoring, self-checks, having some kind of screening process that then will put them into an identifiable system that will risk stratify your employees, whether it's looking at the shifts or how they come into work, or verifying their test information, even saying you now need to go to stage 2 and talk to a healthcare provider. You need to go into quarantine management right now You at minimum don't need to come into work today, or those types of things, or maybe a re-evaluation at lunch. So there's a lot of things to consider. Then you've got to throw in PPE channels and technologies and availabilities and testing, and even types of tests, right? We've all seen information, whether it's serology or PCR or nasal. You saw FDA approved an actual at-home test. Well, all of these have different efficiencies. They have different abilities for people to give themselves or not. Some need caregivers to prescribe, some don't. Some come very quickly, some take time. So these are all things that organizations now have to navigate, and that can be really tricky for organizations that aren't used to clinical management, right? These non-healthcare companies, they're not used to navigating these waters. So it's a double challenge. And when we look at sort of what the next step is, yes, I would say, we talked about the risk stratification of the employees themselves, but also we're starting to see lawsuits and all that fun stuff that comes down the road, as we know inevitably will, that puts potential employers at risk. But as we go into flu season, and if the projections are anywhere close to what we think, it is our responsibility as non-healthcare entities to try to keep as much of this critical mass out of our health systems. We saw firsthand what it did to our health systems when we were able to shut down the rest of the hospital. We likely will not have that leverage this time. So Ben, if you go to that next slide. So we're going to talk about what kind of stresses this has put already and will put on our healthcare system, on our delivery systems of all type. Some of the innovations, anytime you have whether it's war or major recessions or huge effects to the economy, you typically, the only good news you can get out of it sometimes is you will see innovations. And we have started to see innovations, which we can talk about. But I'll tell you, we saw this firsthand, as Kenya mentioned. And I wish we had more time to talk about just the amazing coordination and investment of resources. So I don't know if many of you know, what AMN was the primary engine behind many of those pop-up or field hospitals or added capacity care sites that you saw pop up when COVID hit. And a lot of these were on the frontline states like New York and New Jersey and Southern California and Washington and so forth. And working with entities that weren't used to working together. So state government, HHS, federal, FEMA, Army Corps of Engineers, then you had various departments of health. You had state hospital associations, regional medical societies working with healthcare entities, all in a period of days to stand up these 1,000+ bed field hospitals, again, in under a month. And this took, obviously you need full leadership structures because you can't take it from your existing pathways. Now, this is what you would think of: a CEO, a CFO, a CNO, a CMO, those types of things. But almost think more military. You had to find those that are used to triaging on the battlefield and aligning resources in a rapid manner. Then, of course, you had to find the clinicians themselves. You're talking thousands of clinicians of all modalities and non-clinicians for that matter, but recruiting them, assembling them, employing them, having technology around scheduling, being able to make sure that you have all the scopes of care covered, then getting into who gives the badge, who pays them, who follows the HIM, who makes sure funding channels are seen, who runs that technology on the telehealth or other sides. And then we saw that these were designed for 2 weeks and many of them went on for 2 to 3 months. So now you have talent relief and you have to start looking at more efficient ways to give care and then care team design. My point is, when you throw that on top of community testing sites, then ultimately we pray a vaccine that comes out. Well, most people forget that in a probably best case scenario, we get a vaccine that's maybe what, 75% efficient, and they don't magically all go to your door, right? And you just stick it in your arm yourselves and you're vaccinated. Then you have to administer it. You have to triage who gets it. You have to take care of your highly vulnerable populations. You have to get it into your care workers and transitions of care type limits. So think of the stress that has already put on our healthcare system. Now think of trying to do that again if non-healthcare companies don't have strong return to work programs to mitigate this risk the best we can. And again, saying that we can't shut down the hospital to do it. If you go to the next slide, Ben, we talk about some of the innovations, and we'll get into this a little bit in the Q&A, but any health system or delivery system worth their salt, there's really nothing they haven't looked at with fresh eyes. When we talk about leveraging sites of service, I could easily say the care teams that go behind it, now taking healthcare beyond the walls of the hospital. Again, these aren't new concepts, but think of pouring gas on that fire, right? Especially when you have millennials who already were challenging the system to get their care in different ways, right? They didn't have a primary care provider. They had a collection of urgent care visits usually. So how do we now take that, which is going to be ramped up through telehealth and your other portions of the population, that 15% that drive roughly 45% of our utilization, has been mentioned. And then trying to pair that with, whether it's working with the lab companies, whether it's PwC or Johns Hopkins or whoever it is, trying to predict outbreaks or populations at risk. A lot of that you can do, as it says here, and has been alluded to social determinants, those highly vulnerable care populations. We're already starting to see, unfortunately, some really negative stories when you get into nursing homes, that types of things. But what it led to, and Ben, if you'll hit that next slide for me, what it led to is doing things differently. And I put this quote up here because I hear it too much. You hear a version of this as, we just can't wait till it gets back to normal, right? We can't wait till things shake loose. And I'll tell you that if you're one of those organizations that are just trying to do it the way you did or get back to the way it was pre-COVID, you're probably going to be left in the dust. If you're one of those organizations that are leaning in or innovating and say, you know what, we're going to use this as opportunity to look at care team design, care delivery, service line expansion, maybe even service line competency. Do we need to be everything to everybody, which was maybe your previous notion? Even getting into communications between those specialties and those service lines. That then leads you to, do you need leadership pods in the current format? Do you need those cost structures? Every organization, healthcare or not, are looking at, do we need to rent? Do we need to own? Do we need to change our footprint, right? And then that will lead, as we said, to new care teams, but new roles within the clinical system. We're already starting to see that, specifically around primary care, where they need to morph from this frontline caregiver to this quarterback of a value-based system. Again, not a new topic, but certainly one that has been given new life, as it's not going to be a nice to have, it's a necessity. You're seeing that push. Healthcare systems of all size are already starting to take their quality or outcome-based care programs. Most of them had anywhere between a 3 to 5 year plan to move to that direction. So it's not too much change management, too much change to their clinicians, too much change to compensation, let the government catch up with them, et cetera. That now is accelerated into a 1 year plan. Why? Well, primarily, it's been said, because we've been so reliant on these fee-for-service channels. You have two people now coming to the table saying something has to change. Our utilization, our productivity has gone down to nothing. So we'll talk about other ways within these rabbit holes that people have innovated. But before we get into the real conversation, I want to leave you with the last slide. Because again, I get this feeling, and this is probably more the non-healthcare companies. I get this feeling that they're waiting for someone to come save them, right? The government's going to step in, the state's going to step in, the CDC is going to step in, a vaccination is going to roll at our front door. I can assure you that all those things are probably going to happen, but no one is going to save you. We have got to plan for this ourselves, and the better these two indices and our 360 view work together, I think the better position we'll be in too. But let me pass it back to Kenya, maybe to get into some specifics.
Well, Ben, did you have a comment?
Or Ben, sorry.
No, that's great. Yeah.
Well, but what I'm hearing in the tension here is Ben is talking about, as a result of the pandemic, you have a lot of employer-based plans that are scaling back, and people are having less access to their employer-based insurance. And that's really what we rely on for the value-based care that's going to be the 360 care that we're expecting. So if you don't have that employer-based private insurance, we will see it through Medicare. But what about that workforce that's under 65? What's the solution there? I mean, I'm seeing a lot of retail, but is that retail supposed to be cash pay? I mean, what are we looking at?
Yeah, I mean, I can make one comment to that. I think one thing that's really kind of underutilized in the US right now are the health insurance exchanges. And part of that has gotten because they've gotten kind of swept up in the politics of the ACA, repeal, replace. this, that, and the other. But the reality is a lot, and because the marketing budgets were cut, there's a lot of people out there that actually would qualify right now for one of those exchange plans that could potentially be very heavily subsidized. So those are on a sliding scale. And so people that have been laid off or don't have, the funds could get, could get some insurance. And the thing about those plans are they're actually very robust. They cover a lot. So I think that's one option. One thing that's been surprising in terms of access is we've not seen a huge increase on the Medicaid rolls around the country. So there's just been a little bit of a blip, and one would expect that as people became unemployed, they would, immediately kind of move over to Medicaid if they're unemployed. The reality, what's happening is some people, a few might be switching over to like COBRA, a few are being laid off, and maybe they can keep their insurance for a little while, but we're still back to the same problem that we have with the insurance exchanges. Most consumers don't know how to navigate the insurance landscape. If they've gotten it through their employer, it was on kind of, it was self-running, they weren't thinking about it, and then when they don't have it, they don't know about all these other options.
Also, that even extends to the healthcare side of it. Literally fresh off the presses was released today. So we do work in conjunction with the Physicians Foundation. It's a well-funded think tank that does many different studies, mostly on the physician, sort of the life and space and morale of a physician. And like Ben's studies, we did pre-ACA, post-ACA, now pre and during COVID. Our last survey was to 800,000 physicians, so essentially every single one of them. And as we've been taking temperature checks through COVID, one surprising data point I saw come out of that was 75% of physicians feel that the primary indirect harm that COVID will cause is a lack of insurance because they're changing employers. And their patients calling them, because they don't know who else to call, about what to do, how to navigate it, right? And you compound that with utilization patterns that I think we're all trying to project the best we can. I mean, I can tell you that just last week, talking to utilization, so delivery systems from coast to coast, you've got some that are still 20% of utilization of what it was last year, pre-COVID. And those may be in your highly populated, high at risk states like a New York or New Jersey. You have some that are 140% of non-COVID utilization year over year in those small mid-market type communities, because you have all that pent up demand in that preventative care. So I think the jury is still out a bit on how much of this lack of preventative care, how much of this lack of routine care, what will be the effects on utilization of making the patient become their own doctor. The best example I can think of is you talk to those high risk chronic complex that maybe they say, Dr. Smith, I know you said I need a scope, but I don't feel sick. And I know you say maybe I'm at risk, but I don't really have the funds to have that procedure. And I really don't want to put myself at risk because I know I'm going to have you come into your office to get that procedure. So I'm just going to delay that. Well, we know that's going to have ramifications. What will it be? That part we don't. And then that's going to cause utilization channels that hopefully insurance and employers will be able to respond to quick enough. But I can tell you, as much as the payer side of it, which we can certainly go down that road, there's just an ability to give that care if you have insurance or not, which should scare all of us as we go into the flu seasons to fall.
So, as we are just in the crosshairs of a number of things going on, right? We still have the economic crisis, COVID, we have an election coming up, and then we have our Texas legislative session next year. So do you think that the events of this year will impact the continued conversation over Medicaid? A lot of it is Medicaid managed care, we know, which again goes to that value-based idea of having a continuum of care. But do you think there'll still be a lively debate over Medicaid for the coming legislative session?
I guess from my perspective, I think there will continue to be one nationwide. We're already seeing some states, because of the economic issues, saying like, oh, maybe we should have expanded Medicaid. And certainly if there's a change in the White House and potentially in the Senate, I think we'll see some more states move. Again, just going back to like how Medicaid rolled out originally, how the CHIP program rolled out, in the late 90s, is that eventually every state got there. It just, it took time before kind of the politics and the economics aligned in the right way. So I think that'll be a very big thing to watch post-election is on the Medicaid piece. One other thing that I would just bring up, and this is not necessarily policy oriented, but Travis and I both talked about this major shift in delivery. Yeah. And so moving to virtual delivery, and there's a lot of amazing things about that. What's interesting is what I'm hearing, now no one's gonna say this publicly, but what I'm hearing from health system CFOs is that actually they're losing a lot of money on virtual delivery. And that's even with parity right now between an in-person visit, because they're not getting the ancillary services. So that in-person visit, when you go in and a doctor says, well, you need an X-ray, an MRI, lab tests, you're right there in person. And a lot of times that is going to convert and you're going to do that. And that is more revenue. If you're having the visit virtually, you might not do that. They may say, well, you need to go get an MRI, but you kind of put it off and don't worry about it, or you don't walk down the hall and get your labs. So I think there's going to be, as we move into the next year, the train has left the station. We're moving a lot of this stuff to virtual. I think the question mark is going to be, can kind of the higher cost parts of our health system, like the academic medical centers, the research centers, what are they going to do to kind of make up some of that revenue? So that's the other thing that I would watch. There might be a policy solution to that, or it might be just a pure kind of business. How do we lower our cost structure?
I think that's really important. When you look at the telehealth innovations, I mean, first, I think there's a misnomer of what happened. I think there's this thought that, we spurned on technology because COVID made us. No, we've had the technology for a long time. Then maybe it was hospitals didn't want to use telehealth or didn't trust it. And no, that's been in place for a long time. Or maybe it was providers didn't want to use it. And frankly, there was some of that, but that wasn't it. The barriers were reimbursement and regulatory environment. That's what COVID did. COVID knocked down barriers that would have taken generations. Well, heck, on this Congress, maybe 2 generations to take away, right? So that's what makes it scalable and what makes it spread. Now, for all the positives of that, Ben mentioned, and we still don't know, the jury's out on what reimbursement and regulatory will look like. I think if you look at Pence team's original comments and then whatever they're dripping out, I think we feel somewhat confident that while it's not going to be a 100% reimbursed event as compared to an inpatient visit or an office visit is now, we think it's going to be between 70 and 95% depending on the scope. We also think that scope of care that will be serviced through telehealth is going to be much bigger than we originally thought, right? So to me, that takes telehealth from a niche that maybe you sold as something you were being progressive to a responsibility of a care pathway. Fundamentally, financially, this is now a care pathway. Well, the problem, to Ben's point, is even the best organizations, Kaiser comes to mind because they've had a significant portion of their primary care through telehealth for years already. And a lot of these other provider-led organizations like a Mayo and a Cleveland Clinic who have been strong fundamentally in telehealth, even they are struggling with, when doing this at scale, what will that scope look like? Do your physicians know, or the larger care team know how to practice medicine through that? What is the communication through your telehealth to that full care team, which ultimately ends up capturing that downstream revenue and even those walk-in visits and referrals and those types of things? Your platform can mean a big difference in that. I know even with AMN Cares, as we're working with groups, we had physicians using FaceTime during COVID, just doing what you had to do, right? Well, that's going to go away. And do you have a bi-directional, high trust, HIPAA certified fundamental tool that allows communication through the entire care team that patient not only uses when they have to, but wants to continue to use? And then as a provider, do you know how to practice medicine that way? Will you scale it to become more efficient, or are you just replacing a pathway, to Ben's point, at a lesser cost or a lesser investment as you did before? And unfortunately, that's where a lot of them lie, because no one has gone through the change management. So I think it's positive. I think we're starting to have those conversations, but I also think you have organizations. And again, we polled the physician population. So if you were to look at 4 years ago, we had about 18% of total physician population that use telehealth in some form of their practice. That's a bit misleading because in that 18%, it was a very small fraction of what they did, maybe just like 2% of their practice. Now, if you look at last April, that number jumped up to 50+% nationwide, some markets as high as 80%. And that's even misleading because in that number, it was all of their practice. They either were doing that or not seeing patients. And certainly some specialties that cater to that to more. So what I haven't heard are how are systems going to redesign their care pathway to now make that a fundamental financial channel. And then obviously the regulatory environment has to come behind. So I think those two hands go together. It's just not there yet.
Yeah, and Travis, just one thing I would just add to that real quick is one question I think we're going to have on future delivery of healthcare is, do we have kind of permanent virtualists?
Yes.
Kind of how we have hospitalists now. And that was something new 20 years ago, the concept of a hospitalist, a doctor who primarily just works in the hospital. That might be one of the solutions to this, where we find clinicians that literally is just their specialty. They know how to do it. They're great at that interaction through the virtual environment, and they can get very, very efficient with it and have the right tools. So I think that's something to watch as well.
Honestly, we're already seeing it. And it's not a CTO, to your point. It's a virtualist. It's someone that understands. And again, you get in, I don't want to go too far down this rabbit hole. You get into billing and coding and leveling, all these things that organizations, healthcare organizations typically don't do a great job of now in person. So how do you do this in a virtual environment? But to your point, all your analytics should change. Whether you're looking at productivity analytics, that what made you profitable yesterday, whether you look at payer mix streams, whether you look at time of appointment, scope of appointment, even getting down to what provider sees what patient when, all those must change. And if we were having real struggles of documenting quality and getting reimbursed at a rate through the government that made this efficient, as they said, in the office, controlling 100% of it, how do you think we're going to do in a virtual environment? And that's where you're going to see these virtualists that come in and actually boots on the ground change management and hopefully put them on the right direction. But it's, to Ben's point, it's not an if anymore. You're either going to innovate and do it, or you won't have that care pathway.
Well, and we're working with clients that are preparing for telehealth post-COVID. So post all of the HIPAA waivers, all of the privacy waivers that we have, the reimbursement issues. So when you get into the compliance that's necessary for each of those states, there are some significant barriers. You know, right now you have some telehealth companies that are just forging forward, and they said, well, we'll see what happens and see if, you know, these waivers stay in place, right? But if you can't use FaceTime, you can't use Google Duo, there are going to be some significant technological barriers, as well as just practical. What kind of entities can you use? Can you use a single entity? Do I have to set up 50 different entities in 50 states to be able to do this? Do they have to be licensed in that state? So, and I think, you know, there's still an anti-competitive issue there. There's some physicians that don't want telehealth, right? So, you know, people are really excited about the waivers that are in place right now, but there are some physicians whose practices are threatened by this era of telehealth. And I think it's still a reality that we'll have to think about.
One can hope we will finally get away with 50 different state regulatory bodies that license physicians that make this just an absolute beast to get any physician where you want. Why we still have that in place? I'm still waiting for an argument that says we need 50 different state rules and regulations to have someone practice medicine in that state. You would think telehealth might be the window that we can finally knock down that barrier, but I voted on Congress before, so I don't know. We'll see.
Well, and I will say, because I do handle a number of medical board complaints and have sat on a state board that licensed professionals, there are a lot of issues out there, and and all states don't handle them necessarily the same.
That's right.
But you know, it doesn't mean that we couldn't tackle these issues. It just means that it would take a concerted effort, and that's not necessarily what we're the best at right now. You guys talked a lot about deferred chronic care, and you know, what do we really think the impact of that deferred chronic care is going to be on the health system in the next year or so?
Well, you know, I think we're going to have an impact, but you know, on a lot of different levels. I mean, I think in communities, obviously with individuals and families, the health system itself, but also the folks paying for healthcare, and that's why I always like to bring in the employers. who actually insure, more Americans than Medicare and Medicaid combined. This deferred care, you have to kind of drill down into it the next level. So, I mean, there's some people with chronic conditions that may be hypertension that's very well controlled by their medication. And so if they miss they miss an annual visit, it's, in reality, it's not going to change much for them. But there's other people who have multiple chronic conditions that are always on the verge of it not being controlled. And so the diabetes and COPD and other things that when combined cause a lot of issues. I think we're back to that question of what is going to be deferred and won't come back. And so like a dental visit, that didn't happen in the spring, you're not going to do an extra dental visit, but we're getting back to normal on that. I think the deferring for complex chronic in terms of management, some of that, as we have shown, has moved to virtual. The things I think we're going to be very challenged about and where we're going to see those unattended consequences are those that went for a 6-month period. Now the diabetes has gotten out of control. And so maybe we are looking at something like, a surgery, a foot removal. I mean, something like very, very serious that can happen down the line. So just to sum up, kind of what does that mean for us? I think again, we're as a health system, we're still back to that reckoning of how intertwined our social determinants are, how important this kind of management 360, if you will, of these individuals will be. The pandemic just kind of pulled the covers off of it and really showed how bare we were there. But these are issues that actually were existing even before the pandemic.
Yeah. I mean, we were just now starting to have those right conversations pre-COVID about poverty and social economic investment and how bad the United States is. Really not debatable. Per population, per poverty mix, doesn't matter where our investment was compared to other industrialized nations and the effect that was having on our healthcare system and utilization. To Ben's point, COVID kind of said, look, here's all our uglies. We shouldn't have needed a pandemic to say this, but here's our uglies. Look where we have gaps in transitions of care. We have gaps in our chronic complex that fall to nursing homes, and our vulnerable care population is next to nothing. So we've actually seen states get a bit creative with COVID funding and start directing that to really what I would call social economic investment, right? Which is probably where that money should have gone anyway, to protect our healthcare system and to protect our non-healthcare employers. So I think you will see a compounding of that. I think there's no doubt that our treatment of the chronic and complex had to change, and I'm hopeful that this will spur that change. Most of that falls to primary care and redesigning what the primary care workshop looks like and what the primary care provider does and who gives that frontline care and how that care team works, which again, these are not new conversations. It just took a pandemic, evidently, for us to actually kick some of these things in gear. Telehealth will play a huge role of that. Obviously, you would hope that reimbursement and other channels come by that. But even if you look at the investment we've seen in socioeconomics since COVID, you've started to see that go to channels that we hadn't seen pre. So I don't know. I think that's actually a positive. I think that may actually give legs to that conversation. Is it going to be fixed to the degree that Ben talked about where we need it to be? I don't think we have a chance. But I'll say again, I think who gets the White House maybe this year more than any of the previous elections that I could think of is a fork in the road that causes so many different avenues because of the environment we're in. I know you can say that every year about healthcare, every election about healthcare, but I really do feel like we could go one of two directions, and that's going to cause massive ramifications, positive and negative on both sides. It's a crazy time.
Travis, I wanted to pick up on what you mentioned there. One of the stats that it's a little bit of an oversimplification, but if you look at the Northern European countries and kind of the dollar they spend on health and social, about 75 cents is going to social services, 25 cents to direct health care. In the United States, we're exactly flipped. And so, in some ways, if you just look at it from pure kind of like capitalistic economics, why is it that people are going to the health system and saying, build housing in California? Well, that's where that's where the money is in the health system. It's not in the social service system. And so I think for those of us that are in the health system, people are going to be coming hat in hand over and over and over to pay for things like nutrition,
Yep.
parks, housing, because that's where we spend our money. 75 cents on every dollar is going to health, not social.
And it's, I don't think a coincidence, those same countries, when you look at the design of their medical system. So most of them are roughly 50-50, if not closer to 70% primary care, 30% specialists. The United States is exactly opposite, right? And I don't know what the right mix should be, but I don't know that we should be the exact opposite of all others out there. And when you chase that dollar. So I think it's a positive that that's going to put light and unfortunately show some very big gaps and negative holes in our healthcare system. But if reimbursement doesn't follow that, same thing that we talked about with telehealth, it will be for naught, because they'll revert back to their old pathways that they get paid for, because that's where the money is.
Yeah. Yeah, people do what they get paid for. Is that the
Oddly
sum of our
enough.
presentation today?
Oddly
Well,
enough.
we have a couple of questions in the chat, and I said I did want to give enough time for that. Ken, do you want to handle those, or Marina?
Yes, that'd be great. The one that I think that I'd really like to get to is Stephen Angelette, who is a board member of the North Dallas Chamber of Commerce and a partner at Polzanelli. So Stephen, do you want to go ahead and ask your question? Oh, can't hear you, Stephen. Oh, there you go.
Sure. I think, Kenya kind of half answered it with the physician compensation, and Travis's joke about people doing what they get paid for kind of half answered the question. Seems like anecdotally that telehealth usage has gone down in the sort of more recent months of the pandemic versus, the first few. Any thoughts on whether that's actually the data reflects that, and whether that, what that means? I mean, obviously there's kind of a moment here where it feels make or break for telehealth because of the, the Medicare waivers and some other things. And that momentum could be lost as people get more comfortable, maybe going to see their doctor during the pandemic. But just curious what the data and your thoughts about that.
I give a first stab. Ben may have some different analytics as well. So we've really seen it come down to two camps. And again, to oversimplify, those that are just trying to get back to where they were before, and those that are really trying to lean in and innovate. You have seen some pretty disappointing stats. So I talked to a CMO or C-suite 2 months ago, and they talk about, we went from 5 telehealth visits a week to 5,000 over a month, right? And now this is going to be 60-70% of our primary care, whatnot. And you talk to them 3 months later, and they're back down to where they're only seeing about 10,000 visits and shrinking. So then you ask, well, why is that, right? A lot of that has to do with the change management that wasn't put in place. So you had providers that were doing it because they had to, but not because they saw it as a way to become more efficient or see more patients or have better quality of care. There's a great study out on first user experience on the patient side. So in other words, if you're a patient, and I don't care if you're millennial up to baby boomer, doesn't matter. If you're being forced, quote unquote, to see your care provider in a different way, how that first experience goes says a lot about whether you'll come back to that type of experience again. And unfortunately, you had so many health systems just doing it on the fly, right? Not trained, not right portal, not all those types of things, that you're starting to see that come back. You've got other organizations like a Geisinger or a Kaiser, which have leaned into it and actually have sort of mandated that care pathways will go through this right care, right time premise, triage, and then go to next steps. So I think you're probably going to see a fork. I wish you weren't, but you're probably going to see a fork regardless of reimbursement. But you also have seen enough change fundamentally that even some of those organizations that revert back, right? Mostly because their providers aren't pushing it. Let's be frank, that's mostly what it is. You're going to see even some of those come clawing back because the organization is going to force that usage because the scope of care is wider and the reimbursement is going to be a little bit better than we thought. Ben, you may have something that differs from that.
I don't have anything that differs from that. I don't have any of my own data on, I haven't run a consumer survey, in the July-August timeframe. We are going to be running one this fall. So I will have more to talk about, let's say in the November time range. So I mean, the only thing I would add to that, what Travis said is, we've also got to look at the financial incentives for consumers. And so I'll just go back to the employers in terms of what are they going to do in terms of cost sharing between the in-person visits and the telehealth visits. And so we may see some really nice incentives for consumers to continue to use telehealth. So that's number one. Number two, I would say, is in general, healthcare is always super sticky. People don't want to change once they get their groove. So we saw this back in the early 2000s with retail health, that it kind of had a slow start. And then eventually there was enough retail health out there and people saw this is really convenient. I could have a visit and get my prescription right in the same building. And so now retail health is just a part of the fabric of our world and we don't know any different. I think telehealth will be there. It won't be at those levels we saw when the whole health system was shut down and it was literally the only doorway. But I don't think we're going to go back to telehealth being a very niche 1% type situation.
No, but remember, I think you said this, Ben, remember the headlines going into COVID about healthcare. What were they? They were physician burnout. They were bad morale. They were access to care, right? There was, overburdened healthcare system. And then in times of war, for any of you nerds like me, like to study old generals of war, one or two things happen. You either all come together and you circle around the mission and titles and compensation be damned, you just do what you got to do, or every little thing becomes insurmountable and you fragment apart and you go away. I would argue we've seen both in COVID. You saw people come together. Now you're seeing all those little things that were there before COVID show their ugly head. And if telehealth can become an answer to some of those issues around morale and utilization and effective use of care and experience between a patient and giving the provider a different type of experience or quality of life, as it could and should be, then you're going to see those organizations adopt that utilization and it's going to peak. If you don't, and it's not pushed, to Ben's point, we can't rely on the consumer public at large to push it. Some will, millennials will, some chronic complex grouping will, but it's going to have to be driven by, I think, largely by those providers. If you can't change that behavior, money's a part of that, then it's going to be tough to scale it.
Great. We have one more question, and I think that we're going to have to conclude this call. So Marino Orlandi from First United Bank has a question. I think part of that was already answered, but Marino, do you want to try to unmute and ask your question?
Yeah, thank you. Hopefully you can hear me okay. But yes, it was partially answered. But as a banker, I have to think about assessing risk. And when we lend money to healthcare providers, we're interested in their ability to repay. Given what I've heard about telemedicine, how things are changing and the potential revenue, particularly on independent physician practices, Ben and Travis, I'd love to get your thoughts on the health of the practice, their financial viability, and how this impacts their cash flow, and i.e. their ability to repay the bank.
Yeah, this one is near and dear to my heart. Ben, you and I have talked about this several times, the life of the private practitioner. Early estimations are we're going to lose close to 30% nationwide of our private practice because they can't, small business costs, rising compliance, regulatory environment, all those types of things. That's going to vary by market. It's going to vary by specialty. I think that I don't know that we're going to see the end of that balance sheet maybe for another 6 to 8 months. Frankly, half the people we're talking to that were barely hanging on just got a PPP check. So what happens when that goes away? What happens when the utilization doesn't rebound? So, and they're in a segment of healthcare maybe where they can't translate their care to COVID Direct or can't translate their care to telehealth as effectively as someone else. They will probably be consolidated, bought, or others. The other part to your question, before I pass to Ben, that I love the interest in investment in telehealth, specifically in healthcare. I love that private equity and other types of funding are now coming into healthcare. I'm not sure the speed and the retail niches that we're seeing with it all shake out to be a fundamental care pathway, but I'll pass to Ben to have some thoughts there.
I don't know that I have a lot to add there. I mean, I think Travis covered it really well. I mean, just I think some of this is so geographic dependent. So when we say pandemic, I mean, in some parts of the country, it's like there's nothing going on. In other parts of the country, everything's going on. In other parts of the country, they've kind of come through it and things are getting back to normal. So we're kind of all over the map when it comes to what's happening. The one anecdotal thing I can say is I've had several physicians that have, over the past couple of years have been bought or part of larger groups or hospital systems. They're kind of like wiping their brow and saying, woof, thank God I was bought a couple of years ago. I'm still getting a paycheck. And so, I think it goes back to Travis's point, the independent physician, yeah, I think you really have to do a lot of due diligence. Like, is our landlord giving them a break on rent? What's COVID doing in that exact area? I think there's just more underwriting to do now that maybe didn't have to be done a couple of years ago.
Yeah,
And I'll
thank
just
you.
say, just working with a lot of different physician groups, even pre-COVID, many of them were investing in other business
Yep.
entities and other ideas. So we had an orthopedic surgeon whose partner sold the actual equipment that he was placing in people in these ortho procedures. And he said, wait a second, the guy who sells the equipment makes more money than I do, and I'm a surgeon. So many of them were already trying to figure out how to diversify where they are. So I would say I would really partner with and seek out those types of physicians that are thinking from the business perspective as well.
Okay, thank you.
Thanks all of you for being here today and participating in this program. And thank you to Kenya for arranging this program and arranging for Ben and Travis to be our guests today.